welcome everyone. I can't see anyone and you can't see me, so I'm sorry for that. So I was asked to teach you or take you through general kind of metabolic, a general approach. So I think it's there's a lot to cover, but I've tried to keep it as simple as possible. Because I'm fairly simple. So I'll just give you a quick overview of, so IMD is inherited metabolic disorders. It's a short, or you might sometimes see IEM, which is inborn errors of metabolism. The different types, I'll go through some of the investigations that you might be asked to send or have sent and don't really know why you're sending them. A little bit about newborn screening, because I think that's fairly important, and some useful kind of bits at the end that might help you in daily life with IMDs. So clues in the history really for metabolic conditions. Onset of symptoms is occasionally helpful sometimes, but a lot of conditions can be either acute, so an acute metabolic decompensation, fairly chronic and insidious and present later on, or intermittent episodes of decompensation. So it's quite broad, so that may not be that helpful occasionally. There may be associated triggers, so episodes of intercurrent illness, fever, anything that is associated with fasting or induces catabolism essentially. There may be a history of specific food aversions, so for example for urea cycle defects proteins, for hereditary fructose intolerance, aversion to fructose or fruits essentially and sweets, and then those children tend to have kind of fairly good dentition out of keeping with the norm. And then is there a family history? So is there a family history of neonatal deaths or early infant deaths, potentially of unknown cause? Is there a family history, particularly in males, suggesting an X-linked inheritance? And then obviously taking a good family tree is important. Is there consanguinity? So our parents, and we normally, sometimes that can be a difficult thing to ask, but I tend to say, are you and dad or are you and mum blood related in any way? And most people take it fairly well these days. And then is there a history, an antenatal history or a perinatal history of maternal HELP or acute fatty liver of pregnancy, which has been, it's not very common, but has been reported in infants who then go on to have normally a long chain fat disorder, so not that common, but has been associated in the literature. And then examining children with, I'll go through this very quickly, so examining children with metabolic conditions, again, not very specific. So some of our conditions cause dysmorphic features. I'll go through those a little bit later on. I tend to look at kind of the status of children's skin, hair and nails and see what sort of condition they're in, suggesting good or poor nutrition. Is there any organomegaly, so hepatosplenomegaly essentially? Has someone looked at the eyes, or can you look at the eyes looking for things like cataracts, probably at the bedside? And then a full neurological examination can be useful depending on what you look for. So our examinations tend to be fairly focused, and a musculoskeletal examination if that's appropriate. So essentially a basic metabolic pathway, I'm sure you all know, is the term was had come about in the early 1900s, so one gene, one enzyme, and now obviously it gets a little bit more complicated because there's also various transport proteins that can cause our disorders, but essentially enzyme deficiencies. So if you have a deficiency or a block between B and C, what you would then see is an accumulation of A and B, so prior upstream or proximal to the block, and then a reduction in metabolites or substrates downstream from the block, and they may be important, so something such as glucose. And then what can also happen is that the accumulated metabolites have then been directed down an alternate pathway, and that may produce other metabolites which are also toxic. That's the basis of the majority of our conditions, but not all. It's a little bit more complicated, as you can see by that. So this is just a kind of an overview of kind of classification, I guess, of metabolic disorders. So broadly, I sometimes say to parents, we look after children with conditions that are to do with breaking down sugars, fats and proteins, but again, it's much more complicated than that. So these tend to include intoxication type conditions, so we can use that as a classification. So these can be either acute or progressive decompensations, if you like. So the acute ones are the ones that cause hyperammonemia, so urea cycle defects, organic acidemias. Galactosemia can cause liver failure, so that's an intolerance or inability to break down lactose or galactose. PKU tends to cause a much more progressive neurological presentation if left untreated, so it's not an acute decompensation as such. And then we can think about disorders of energy metabolism, and that would encompass pathways to do with gluconeogenesis and glycolysis, so GSDs, glycogen storage disorders, and mitochondrial diseases, and then disorders of more complex molecules within the cell, so peroxisomes, lysosomes, and then congenital disorders of glycosylation are another complex a set of disorders, which obviously I won't go into. And then we can think of neurotransmitter or seizure disorders as a separate set, really. So these are things like NK, non-ketotic hypoglycemia, and tyrosine hydroxylase, and AADC deficiency. Again, these are very rare seizure disorders, but I'll go through the investigation of some of these. And then, so if we look at intoxication disorders as the first classification, so these tend not to cause symptoms straight off from birth unless they're extremely severe. So they don't cause any congenital abnormalities or any dysmorphic features. They can present acutely, so often with vomiting, encephalopathy or seizures, and sometimes liver failure, or be a bit more progressive and present with developmental delay, failure to thrive, and potentially a neuroprogressive disease. They tend to present with a symptom-free period, but that can be often days in the acute situation, and depending on the severity, or can be months or years and plod along for a little bit. And those decompensations tend to have a trigger, not always, but like I said before, tend to be triggered by intercurrent illnesses, fevers, fasting, or anything that causes a catabolic stress, so surgery, for example. And then the diagnosis of the majority of these types of disorders is possible with just a basic screen by sending plasma amino acids, urine organic acids, and acylcarnitines, which is what we often ask for in the acute situation. And most of these are treatable, but not all. And then the general principles of management for these intoxication type disorders is one, to omit the toxic substrate, so whether it be a protein, a fat, or a sugar. You need to try and promote anabolism with obviously adequate calories from whichever source is not toxic, was not causing toxicity. So for example, in urea cycle defects where protein is toxic, you want to remove that, but you then provide calories with carbohydrate and fats in the acute situation. And then the use of alternate pathway medications, so trying to reduce production of toxic metabolites or increase clearance. So ammonia lowering agents, so you may have heard of sodium benzoate, sodium phenylbutyrate, and carnitine, which can conjugate organic acids, and then glycine, which can also conjugate organic acids. And then other more invasive methods. Oh, gosh. Sorry for that. So other more invasive methods of clearing toxic metabolites, so hemofiltration, sometimes peritoneal dialysis if the baby's too small, and transplantation ultimately, but obviously not in the acute situation. And then more long-term, we use emergency regimes, which may tend to include, for the majority of disorders, carbohydrate as a source of energy during intercurrent illness, so sick day regimes. And then these children tend to have quite intensive and specific restricted dietary regimes, which are monitored and supervised by a metabolic dietitian. So basic investigations, we may ask you to send, so plasma amino acids when you're asked to send them. This is the kind of, and these are what we're measuring. So these are the, well, we say 20 amino acids, there are a few more, but so we have essential amino acids, which means that they're not, that they are not made, and you need to take them in your diet. And then conditionally non-essential, essentially. So if you look at the diagram here, this is the urea cycle, which is based in the liver or in hepatocytes. And the urea cycle is able to make citrulline, you're able to make arginine, and you're also able to make ornithine. So they can become deficient in urea cycle defects. So we can use these or levels of amino acids to look for specific disorders. So we look for specific patterns. So that's one of the reasons we'll ask you to send a plasma sample for amino acids. Another baseline test we may ask you to send you is an acylcarnitine, and this tends to be a dried blood spot or can be on plasma. And we tend to use acylcarnitines to diagnose fatty acid oxidation defects. So this is a bit complicated, but essentially it's showing where carnitines act. So it's transport of fats, essentially in the form of carnitines into the mitochondria to undergo beta oxidation, and ultimately all these pathways are forming energy by the TCA cycle within the mitochondria. So we can look at specific acylcarnitine patterns to diagnose fat oxidation defects and sometimes organic acidemias, or we can diagnose organic acidemias because the organic acids conjugate with carnitines, and we can again see a specific pattern. And acylcarnitines tend to be part of a hypoglycemia screen, but they don't always need to be done at the time of hypoglycemia, because again, if we're looking for a fat oxidation defect, the abnormalities will be there regardless of the hypoglycemia in the majority of the conditions, but not all. And then urine organic acids, which is the third kind of basic test that we may ask for. So needs a small amount of appropriately concentrated urine, so the lab can run the sample and look at metabolites. Can be stored in the fridge. We don't freeze it here, but can be stored in the fridge if it's going to be sent the following day. And we look at, again, specific organic acids, and this is just an example of a chromatogram showing propionic acid acidemia, and this is what we'd see. So these are the metabolites specific to propionic, and that some of them the peaks are very high. So the methyl citrate is very high, and the propionate metabolites were extremely high. And the other kind of metabolites we can look for is orotic acid in urea cycle defects. We look and see succinyl acetone in tyrosinemia type 1, and we can detect other specific organic acids. The result can take sometimes up to a week. We can get it in a few days, but we also have the ability to run a lot of these chemicals rapidly on a small plasma sample, but not all centres have that ability. And then urine amino acids, they tend not to be particularly useful, and we only really ask for them in specific situations. So I wouldn't send urine amino acids as part of a basic metabolic screen. So they were intoxication type disorders. So disorders of energy metabolism, we can think about pathways within the mitochondria and pathways within the cytoplasm. So if we think about within the mitochondria, these would cause mitochondrial disorders or disorders of energy metabolism where ATP is not, or the production of ATP or utilization of ATP is interrupted. By whichever means. It may be an enzyme deficiency within the pathway, it might be a transporter. So these often affect organs which require lots of energy, so heart, muscle, liver, and the brain, and they're often severe. The majority at the moment remain untreatable. We need to think about these when we are presented with a neonate with a severe lactic acidosis, often seizures, and we need to look, and we can look for respiratory chain complex activity tends to be muscle tissue. We're moving away from that a little bit because we have the ability to diagnose a lot of these conditions genetically. Chemical tests can be helpful, and I'll talk a little bit later about lactate and how useful it is. And then disorders within the cytoplasm tend to be, and there's lots, but the majority tend to be glycogen storage disorders, which will fall under this umbrella of energy metabolism, and can affect the liver, muscle, or heart. There's 13 types. I think there's a few more types as far as I know. I think it's gone up to 15 now. And from our point of view, we tend to see children present with hepatomegaly and hyperglycemia, and that's how they will present to us. And there are liver-specific types, so type 1, 3, 6 and 9, and type 0. They're generally treatable with dietary management, and again we have moved a little bit away from liver biopsy and tend to rely on a genetic panel diagnosis. So glycogen storage disorders, just a little bit about them. So you can see these 3 children here. You can't really predict which one's got which type, and that tends to be based upon biochemistry and ultimately genetic diagnosis. So the children tend to present with big livers, so hepatomegaly, tend to be a little bit short, but with truncal kind of obesity and muscle wasting peripherally, so big tummy and skinny arms and legs. They tend to have short fasting tolerances and more severe GSDs with hyperglycemia. Type 1 tends to cause a lactic acidosis as well as the hyperglycemia, and the other types can cause an associated ketosis, and that's to do with the point at which in the pathway the enzyme is deficient for the different types. So we will biochemically profile these children to see whether or not there is a lactic acidosis, a ketosis, and how soon a hyperglycemia becomes evident, and may or may not perform a diagnostic fast if we feel this is indicated. As I said before, we've moved a little bit away from liver biopsies, but they can sometimes be performed before the children get to a metabolic centre, which will show lots of glycogen within the hepatocytes. And then diagnosis is based on a GSD gene panel currently. So a little bit about hyperglycemia. I know you've got a lecture on this, another lecture on this, a future lecture. But so hyperglycemia, what's important for us is we tend to want to know if it's a ketotic hyperglycemia or a hypoketotic hyperglycemia, and the reason being is that the cause there is a differential cause between the two. So ketones are produced within the liver and following kind of fat oxidation. So if you haven't got ketones but hyperglycemia, it might indicate some liver dysfunction, fatty acid oxidation disorders, hyperinsulinemia because insulin switches off your lipolysis, and potentially mitochondrial disease because, as you saw before, beta oxidation occurs within the mitochondria. And if they're ketotic, it gives us a little bit of a different list. So some of the GSDs that are ketotic, ketolysis defects where you can't break down ketones, and then ketotic hyperglycemia, as I'm sure you've heard of before, but this is really a physiological or an exaggerated state or response to fasting with the production of excessive ketones, and hyperglycemia usually triggered by a catabolic stress of some sort. A little bit about ketones. So the ketone bodies are 3-hydroxybutyrate or BOBs, acetoacetate and acetone. Essentially, they're the end products of hepatic within the mitochondria of the hepatocyte, mitochondrial beta oxidation of fatty acids. And we know that physiological ketosis is common really after the neonatal period. So it's unusual to find a neonate that's extremely ketotic. And we always say that could indicate a metabolic disorder, but obviously not on its own, so with other findings. And then severe ketosis can produce a metabolic acidosis, and we may need to think about ketolysis defects. This particular set of defects are extremely rare, so it's not very common. We tend to see more children present with ketotic hyperglycemia, and then the absence of which, as I said before, may indicate a defect in fatty acid oxidation. A little bit about lactate. So essentially a balance between production and consumption, and this is the pathway. So you can imagine if you're but we tend to see, obviously when we are asked for advice about lactic acidosis, we need to be sure that other causes have been excluded prior to considering a metabolic cause, and these tend to be mitochondrial diseases. Essentially, organic acidemias can also cause mitochondrial dysfunction and hence a lactic acidosis, as can other metabolic disorders and glycogen storage disorders. And you can imagine if you're sort of pouring glucose into that pathway by giving them lots of sugar, again, you can exacerbate the lactate. So sometimes in neonates with a lactic acidosis for another reason, so tissue hypoxia, if they're getting a lot of dextrose, you may see that the lactate worsens. Again, we would ask for these baseline investigations as an indicator of if the lactate is true. So we might see that the alanine is elevated, as you can see here. It's within the pathway. An elevated alanine may also indicate an elevated lactate. We may see lactate spill out into the urine, and acylcarnitines obviously looking for those fat oxides or those metabolic causes, and then other tests as directed. But I would seek advice from a metabolic team if you're worried about a lactic acidosis in a child. And then thirdly, these disorders of complex molecules, I won't talk about them in too much detail, but essentially these are due to disturbed or enzyme deficiencies or protein deficiencies within peroxisomes or lysosomes, and very rarely the endoplasmic reticulum and Golgi apparatus. Symptoms often tend to be not present at birth, but in some of the more severe MPSs we have seen them present at birth, but they tend to be progressive. And these children tend not to have episodes of metabolic decompensation as such, because these aren't pathways that cause deficiencies or defects in intermediary metabolism, and hence not metabolic decompensations. So for diagnostic purposes, or if there's a suspicion of a storage or a disorder of complex molecules, we would ask for urine glycosaminoglycans, and also oligosaccharides are done on the same sample. Very long chain fatty acids for peroxisomal disorders. This is a little one with the typical features: hypertonic, needing supportive feeding with a tube, a large forehead, and probably a very large fontanelle. And then transferrin, so isoelectric focusing of transferrin is helpful, can be helpful in diagnosing patients with congenital disorders of glycosylation, who can sometimes have specific dysmorphic features. And then white cell enzymes or lysosomal enzymes can detect where in the pathway or which enzyme is deficient specific to the different types. And then ultimately, again, we rely on genetic diagnosis, and there are some treatments available in the form of enzyme replacement therapy for some of these MPSs and LSDs. A little bit about seizure disorders, or as we mentioned before, we call them neurotransmitter disorders potentially, but they don't all present with seizures. So we can think about these as treatable really, and they're the ones you want to diagnose first versus non-treatable. So we have pyridoxine responsive or pyridoxine dependent epilepsy, pholinic responsive seizures, and these are kind of grouped together, pyridoxal phosphate, serine responsive seizures. Think about hyperinsulinemia with hyperglycemia causing seizures, which can be corrected, biotinidase, which can be measured, and then GLUT1 deficiency, which relies on paired CSF and plasma glucose measurements. And then these more non-treatable causes, so non-ketotic hyperglycemia is the reason we may ask for measurement of plasma and CSF glycine in a child with in a baby with intractable seizures. Peroxisomal disorders and mitochondrial disorders, as you saw before, these are purine disorders, and we would ask for those as part of our workup. Menkes, which is a copper transporter disorder, and congenital disorders of glycosylation can present with seizure disorders, and then most of those are not treatable. There are occasional ones which are treatable. So just a little bit of a scenario, or not an actual clinical case, but just what would you do with a neonate that has a possible, or what the features of a neonate with a possible IMD. So can have an acute encephalopathy and acute decompensation, and this would tend to be, again, think about your 4 areas or classification of IMDs. They tend to present with poor feeding, vomiting, lethargy, and respiratory distress sometimes if they're hyperammonemic. And there may be clues in the history, as we talked about earlier. Think about treatable causes first in the acute situation. send appropriate investigations. You would want to do, I would suggest measuring an ammonia in any child really that presents with reduced level of consciousness without an obvious cause, and then baseline things like a blood gas, ketones, blood glucose, blood ketones are often very helpful, and then these baseline tests that we've talked about, and then obviously seek medical advice, or metabolic advice should I say. And then the child with developmental delay, so we can think about isolated developmental delay, and this can be a difficult scenario. These can be difficult scenarios with metabolic disorders because it's difficult to give often community pediatricians a kind of standard workup, because sometimes you need to have a look at the features of the history and the examination to see what you'd send. But as a baseline, you would send those baseline tests, the acylcarnitines, amino acids, organic acids, along with CKs, lactates, homocysteine, which can sometimes be useful in children with developmental delay. For us, there's a condition called homocysteinuria. Folate and B12, so vitamin deficiencies, sometimes can cause developmental delays. And ammonia can some urea cycle defects or some conditions causing hyperammonemia or mild hyperammonemia can present more chronically. Biotinidase deficiency, and then those investigations that we talked about for a screen potentially for lysosomal storage disorders would be urine GAGs. And then there's a new set, or not new, in the last few years there's a set of conditions called creatine synthesis disorders, and we can measure some of the metabolites on plasma and urine, and they tend to cause developmental delay, and specifically speech and language delay. And then further imaging can sometimes be helpful from a metabolic point of view. And then there's more specific tests really guided by associated features with the delay. So are there dysmorphic features, as we spoke about before? You may want to look for peroxisomal disorders with very long chain fatty acids. And you may want to look at the lipid profile, so cholesterol, particularly looking for Smith-Lemli-Opitz, which will have a very low cholesterol. Are there additional behavioural signs? So sometimes Wilson's disease can present with delay and decline in school performance, as can X-linked adrenoleukodystrophy, which can be diagnosed with very long-chain fatty acids. And then epilepsy and associated epilepsy or movement disorders, you might want to think about neurotransmitter disorders, so looking at CSF studies essentially. So in brief, hopefully I've given you a summary. So to look for intoxication type disorders, we would rely on those three common investigations we often ask you for. Disorders of an energy metabolism, we may ask you for a plasma lactate along with a CSF lactate, may ask for muscle biopsy, but really relying on gene panels these days. And disorders of complex molecules, as a brief sort of screen, we would look for very long chain fatty acids, the urine GAGs, white cell enzymes, and again, genetic diagnoses. And then neurotransmitter disorders, as the name implies, tend to be rely on CSF studies. But essentially, we are moving a little bit more towards whole exome and whole genome sequencing, but we do rely a lot on our biochemistry still. So again, just in summary, we tend to, samples that are helpful for us are a plasma, tends to be a lithium heparin in our hospital, careful ammonia levels or sampling. I think you have electron hyperammonemia at another point, but free flowing needs to go on ice, needs to be analysed fairly quickly. Dried blood spots are useful for us for a number of tests. Urine is also useful, as is CSF. And then enzymology can be on blood or can be on various tissues. And we would often require DNA storing, particularly in the acute situation if a neonate is not going to survive their acute decompensation. If we want to ultimately make a diagnosis, it would be useful to have a stored sample. A little bit quickly about newborn screening in the UK. So I don't know if you know, but there is a number of screening centres across the UK, and they're each linked to a specific metabolic centre. So there's 6 metabolic centres in the UK, 2 in London, Manchester, Birmingham, Bristol and Sheffield, and then there's one in Belfast, which is part of the UK. We screen on day 5, which differs from other countries around the world, and we only screen for 6 metabolic conditions, and 4 of those have been added more recently. So PKU and MCAD have been fairly long-standing. PKU since the 1960s, really. MCAD, which is a fat oxidation defect, so medium chain acyl-CoA dehydrogenase deficiency, has been screened in the UK since 2005. And then in the last, I think, 2 or 3 years, we added maple syrup urine disease, isovaleric acidemia, homocystinuria, and glutaric aciduria type 1. And out of those, MSUD and IVA can certainly present with acute decompensations, and often children with severe disease have already presented to hospital by the time the day 5 result is received. So there are issues around newborn screening, but it certainly has been helpful in detecting cases early, which is the point of newborn screening. So in summary, I hope you can perhaps consider, and IMDs are extremely rare, but maybe consider them in parallel when thinking about diagnoses. They can really present at any age from birth through to old age. We have lots of adult metabolic colleagues. Consider those that are amenable to treatment really early on, and we may be able to alter the outcome for these children. I hope I've given you a little bit of an overview of baseline tests and a few more directed tests. And really, we're always here on the end of the phone to give you advice, because it's much quicker and easier for us to give you advice rather than Googling maybe. So these are just some useful resources. I think the IMDG is extremely useful. It's got lots of emergency guides on it, has a formulary on it now, and has all of the newborn screening guides. This chap on YouTube, I think one of our SHOs introduced me to, but he's fairly good if you watch him. So I think you can search AK lectures, and he goes through lots of different cycles like the urea cycle and the TCA cycle. So if you're interested, he's quite nice to watch. And this is a downloadable app for the Vademecum Metabolicum, which is a nice, useful small book that we used to hand out, but now it's app-based, so that's very useful. So any questions? Thank you for listening, if you're still there. Great, lots of thank yous, no questions.